Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert insight from a webinar titled Practical Insights on HDV Management Expert Answers, featuring Dr. Tarik Asselah, Professor of Medicine and Hepatologist at the Beaujon Hospital, Université de Paris in Clichy, France, and Dr. Ira Jacobson, Professor of Medicine at the NYU School of Medicine and Director of Hepatology at the NYU Langone Health in New York, New York. For the full online educational program, including the clinical focus module, case-based blogs, resource guides, and downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear our first audience question. Dr. Jacobson, in your practice, which patients do you screen for hepatitis delta?
It's become very simple for most experts in the United States. We believe that every patient with chronic hepatitis B, that is everybody who's HBsAg positive, no matter how active or inactive their state of HBV replication, should have at least a one-time test for HDV. Recent studies, particularly in a study that I was fortunate to participate in, looking at a large all-payer claims database, show that the prevalence in the United States of D in B infected patients is about 4%, which we think warrants universal screening, again, at least on a one-time basis. Now, the published guidelines going back to 2018 on hepatitis B from the AASLD continue to say it should be risk-based screening. That is, patients from endemic countries or patients with a history of so-called high-risk behaviors like intravenous drug use. I would note, however, that the first author of the famous AASLD guidelines, the great hepatologist, Dr. Gerald, actually wrote an editorial in 2021 that perhaps we should modify that to advocate for universal screening purposes. That's become the position of myself and most of the colleagues who I speak to about this.
Dr. Asselah, who do you screen for hepatitis delta?
So we do exactly as Ira proposed. We want to screen all patients with HBV infection. We made a national survey in France with around 10,000 patients with Delta. And finally, if we do only with risk behavior for migrants and people who inject drugs, we missed around 20 to 30% of the patients. And I think that as it was for Hep C, if we look only for people who inject drugs or migrants, we make mistakes and we fail to screen many patients. So in the European guidelines for Hep B, as you know, we recommend to screen all HBV patients to screen for Delta at least one time. And then we screen again if there are some new risk factors, or IV drug users, or going back to the countries. And also in some particular clinical case, for example, a patient with increased transaminases and low level of HBV DNA, it could be superinfection with Delta. So we encourage screening, and we encourage more screening with, these new innovations in therapeutics. So in Europe also, it's around 5% of patients with Hep B who have Delta coinfection. It can be very different according to the countries of origin, but we find for the messages for general practitioner, it's too complex to go back to look for risk factors. Which country was born this patient? Is he a high prevalence or low prevalence? Has this patient has the risk factors in his when he was a child? So we find it too complex. So we propose universal screening.
We have a question from William that talks about coverage from third-party insurers and coverage of costs for universal hepatitis delta screening that you both are implying. Dr. Jacobson, we'll start with you. How have you addressed some barriers to coverage for screening patients with hepatitis delta for your Hep B surface antigen positive patients?
I have to admit that in the setting where I practice, a university faculty practice, it really hasn't entered into it. In our population, and I have to admit that we need to be sensitive to populations with less access to, shall we say, all the testing that doctors may want to do. It really isn't an issue. I've never, for example, had a claim for payment for an HDV test denied. I hope that answers your question.
just in France, just for information, it's reimbursed by the National Health System. So it's free of charge, the screening for B, Delta, HIV, Hep C for the patient.
Thank you. And there's some questions here about presentation. So thinking about patients with hepatitis delta, first talking about what patients who are likely to have long-term health problems like progressive liver damage following a hepatitis delta infection.
Yes, I think the knowledge we have on delta, it's very small cohorts that have been followed. But I think we can have general information from what we know for hepatitis B and hepatitis C. We know that fibrosis is most important prognosis factors. So patients with advanced fibrosis or cirrhosis are at risk of developing cancer, hepatocellular carcinoma, and decompensation. So I think that the most important prognostic factors is the fibrosis stage. It's difficult to evaluate in patients with delta because they are not so robust for Hep C or Hep B, fibroscan with elasticity, also fibrosis markers like FIB4. But I think that sometimes if you have normal platelet, normal prothrombin, normal ultrasound, and a low level of elasticity, it could be moderate, mild fibrosis. At the contrary, if there's many abnormality, thrombopenia, etc., it could be more advanced disease. And I think this is the most important prognosis factors. Of course, we have to look for ongoing viral replication. If there's an ongoing active replication, increased ALT, transaminases that reflect necroinflammations, I think the patient is more at risk of going for complications. But I will be happy also to listen to my colleague, Ira.
My intuitive answer to that is that every single patient with HDV is at risk of advanced liver disease. It's a very pathogenic virus. It's long been called the most dangerous of the hepatitis viruses. And yes, of course, it's imperative that we do a thorough investigation of each patient to assess where they are at in the progression of their disease. But even patients whose evaluation reveals no or mild fibrosis by techniques such as serologic markers or elastography, seldom do liver biopsies given the non-invasive tools. I think that every patient with HDV is a treatment candidate.
Thank you. And we have an interesting question from Teresa. For patients that have seroconverted their hepatitis B, would you still screen them for hepatitis delta? And I'll ask Dr. Asselah that question first.
Yes, as you know, the Delta virus need the HBV envelope for its full replication to entry into hepatocyte. And so when you have HBs loss and seroconversion, you cure the Hep B and you cure the Delta. So patients with HBs antibodies and HBs antibodies who had an immune response to B don't need to be screened for Delta. But all patients with HBs AG should be screened for Delta.
Great. And in terms of hepatitis epidemiology, we have a question here, and maybe Dr. Jacobson can start with that response. Is hepatitis delta prevalence increasing now? And if so, why?
I am not aware of data indicating that the prevalence is increasing. The literature is dominated by cross-sectional studies showing what the prevalence is at a given point in time. With regard to incidence rates, I'm sure those data are out there, but I've not seen anything to suggest that there's a substantial rise. Most of the literature, again, deals with prevalence. And I would comment, although it's a little off your question, that from very sophisticated, large data analyses of global epidemiology, the estimates of the prevalence of the infection around the world range astonishingly from anywhere between 12 to 15 million in one widely quoted study, all the way up to 48 to 60 million. And it depends on which article you read, what impression you walk away with. So again, most of the literature in recent years really surrounds this question of what the prevalence is. I don't think we're seeing an increased incidence, at least in my area. But I'd like to hear what Tarik has to say.
Yes, I agree with Ira. We don't have robust data because, tests are not available worldwide. There's not robust epidemiologic data, and estimates go from 10 million to 70 million. I think that this conflicting data regarding the Delta prevalence is that in many countries, in developing countries where Delta is high, the prevalence, we don't have good statisticals, good cohorts, good epidemiologic data. I think what we know is that because of in many developing countries, there's still, unfortunately, even vaccine for B is not implemented. So there has been some data from Polaris, from WHO telling that also Hep B is sometimes increasing in some countries in Africa. And then with the migrants, there's some migrants with the B and with the Delta. And I think also another mistake is that when we see a patient with Hep B alone, we don't repeat screening for Delta. He can have sexual relations, etc. So I think we don't really know if Delta is increasing or not, but we know it's a concern because, as Ira told, it's frequently a very severe disease. So I think we need more robust epidemiological data.
Thank you. And we have another question from Vinod, again about clinical presentation of hepatitis delta. And I think this is a question that we get asked often at our webinars of the differences in patients presenting with a Hep B, Hep delta co-infection versus a superinfection. So Dr. Jacobson, can you outline some of those differences in presentation between the co-infection or superinfection with Hep delta?
Well, co-infection really cannot be gleaned clinically at all. There is statistically a somewhat higher risk of severe hepatitis or even fulminant hepatic failure with a delta co-infection acutely. I'm not sure I've ever seen a case of that, at least none that I've detected, and I do check everybody for delta with acute hepatitis B. The real issue is superinfection. The vast majority of people around the world with chronic HDV infection are generally believed to have been infected serially, although I guess it's hard to prove that. You can't go back in the lives of all these patients. But most of our patients, all the patients that I've ever seen with HDV, I vacillate between HDV and Delta, have presented with what seems like chronic hepatitis B. Large number of them have elevated ALT levels. And it's certainly important in a patient with relatively indolent HBV infection who has an ALT flare to be checked for Delta, because that can be a Delta superinfection that you're actually witnessing in real time, live, so to speak, as opposed to somebody who's been superinfected in the past. That's about the best answer I can give to that.
Dr. Asselah, did you want to add anything to the symptoms, maybe of what you've seen in clinical practice as well?
Yes, it's exactly what Ira told you, is that in the majority of cases of hepatitis, it's no symptoms or general symptoms or small asthenia, something that is not specific. But what we knew also from clinical trials and from cohorts, when we see the NRS, the Gilead studies, we are very impressed by the mean age. It's frequently 40 years old, with a very advanced fibrosis or cirrhosis, with a high viral load and high transaminase, so more active disease. And it seems that we don't have, quality of life studies, asthenia, but I have the impression from just a practice, but it's a rare disease, that there might be more asthenia, more maybe we don't know very well about, extrahepatic manifestation of Delta, because there's always few patients, small cohorts, but it seems that it's frequently a more active disease. So I think that in general, symptoms are not very specific, but I would say that maybe there will be more asthenia, more decrease in quality of life, more anorexia, but we still to implement all this in the future research.
Yeah, I would add to that, at least one longitudinal study I can readily think of, and perhaps an accumulation of data, suggests that up to 80%, 70 or 80% of patients with Delta actually develop cirrhosis within 10 years of the acquisition of the infection. So it's just another way of underscoring the virulence of this disease and the potential for even patients who may appear to have mild disease sitting in front of you to get into trouble longitudinally. The adage that I would repeat is that I regard every patient with Delta as a treatment candidate. We just need to have the right treatment, particularly one that would motivate patients with mild disease to be treated as opposed to observed longitudinally. I know we're going to talk about therapy, but the notion of interferon has been a real turnoff for a lot of my patients.
Speaking of disease progression while infected with hepatitis delta, we have a question from Ira Jacobson. And in terms of what you guys have seen, is hepatitis delta more associated with liver failure or acute on chronic liver failure, or maybe it could be a mixture of both?
Glenn, I think the phrase acute on chronic liver failure is a very specific issue that is dealt with mostly by people who do transplant hepatology or see a lot of patients with severe liver disease. They're very strict definitions for the clinical criteria, some of which include extrahepatic issues like kidney failure in patients with already established cirrhosis. I don't think that's really the issue with Delta. The Delta patients are the ones who get cirrhosis more than HBV monoinfected patients. So I guess you could extrapolate from that and say that once you have cirrhosis, you're at greater risk of ACLF, as we call it, than patients who don't have cirrhosis in the first place. But the real issue here has to do with the inordinately high risk of getting cirrhosis in the first place that the Delta patients have.
Great. Thank you, Dr. Jacobson. And we have a case here from Teresa, and I'll ask Dr. Asselah for his input for this one first. So a patient who has HBV DNA of 508 international units per mil from greater than 10 million HBV DNA copies within a year and has a normal ALT, AFP, not requiring treatment. Would you screen this patient for Hep Delta?
Yes. I think one mistake that we have done in the past is that because, Delta virus reduce or suppress HBV replication in the majority of cases, but not in all cases. In 70%, 80%, Delta block HBV replication. And then people make the conclusion that patients with high HBV viral load should not be tested for Delta because usually you have high Delta and low HBV. But we learned in trial that there was many patients with high HBV replication, and also some patients with high HBV and low Delta. It's why we recommend personalized medicine, HDV, Delta testing for all patients with Hep B. And we have some surprise to find some Delta in patients with high B replication.
Tarik is right that most patients with Delta have low viral levels. And if Delta were a conscious being, it would say, I couldn't care less what the HBV DNA level is or how much viral replication is going on. All I need as Delta virus is HBsAg being manufactured in the patient's liver.
That's a very good point. And now I wanted to move on to treatment because we have a handful of questions about treatment. And before we go into some details of questions, I know Dr. Jacobson, you mentioned that really if you could treat all your patients with Hep Delta, there any obstacles with treatment, you would. And I'm interested to know, to Dr. Asselah, what's your approach on Hep Delta treatment? You have at least more options than we do here in the United States. So can you just briefly talk about how you approach patients for treatment for patients with Hep Delta?
Yes. So we consider also, as Ira, that all patients with Delta are candidates for therapy because it's a rare disease and it can go rapidly to cirrhosis. And we don't have good markers to diagnose progression of fibrosis. So all are candidates. So then, if we try to make like a priority list, which is not needed because we consider treatment for everyone, but those with, of course, advanced fibrosis, high viral replication, high ALT, high transaminases, could go for treatment. We have the option also for clinical trials, and we have the option in Europe for bulevirtide and pegylated interferon. So many doctors will do bulevirtide as monotherapy, as maintenance therapy. Other doctors will do the combination of bulevirtide plus pegylated interferon to look for a synergistic effect and for a short duration of treatment of 1 year to try to find, after the end of therapy, a maintained response with normal ALT and undetectable HDV RNA. So there are these options. And sometimes for patients with zero fibrosis, for normal platelet, for everything normal, we would say, I'm not very motivated to start a treatment, to wait for future therapy or to go for clinical trials. But we consider treatment for all the patients.
We have some questions here about, I know you're saying treat all patients, but is there anything special to consider for patients that are, immunocompromised, or patients also co-infected with HIV? And Dr. Jacobson, if you have any mention of what you might do with those patients differently in considering Hep Delta, or, even having the discussion of starting interferon.
If we pretend for a moment that we get approval in the U.S. for bulevirtide, my intention at the present time would be to start essentially all my patients, including those in the categories that you mentioned, with bulevirtide monotherapy, and reserve interferon for patients who are having suboptimal, let's say less than 2 log reductions in HDV RNA levels by, say, week 24. I mean, all these guidelines are eventually going to be worked out, and there'll be recommendations and opinions, but that's the way I currently perceive it. I'd love to hear Tarik comment on what he's doing with most of his patients. We have a German colleague who's been very famous in this area who mentioned to me that his practice at the present time is to use bulevirtide monotherapy in virtually all of his patients. I truly hope I'm not misquoting him, and I'm not going to give his name, but I think that's the prevailing practice in Europe. But I'd love to hear what Tarik has to say.
Yes, I use the 2 strategies. If I do bulevirtide as monotherapy, it's a maintenance therapy for a long term. So from the beginning, you have to say to the patient, we will start bulevirtide, it's one subcutaneous, but it will be several years. And now we have some patients after 2 years, 3 years that said, it's difficult to maintain this treatment all these years. So I think why it's very important from the beginning, from the medical education, explaining why this treatment is important to stop viral replication, to maintain this treatment, but it's a maintenance. And some other patients, especially those who are young, we said, maybe, but we don't know, if we do pegylated interferon plus bulevirtide, it's more for a rationale for a finite duration therapy for 1 year. And we could stop, of course, we stop interferon because of the side effects. And we discuss about maintaining or not bulevirtide. I think at this time, we don't know the response, and we don't know of these 2 strategies. And because of the side effects of interferon, many people will go for bulevirtide alone. But in the beginning, we find that it could be synergistic. We don't have the results. We have only the early result at 24 weeks, telling that with interferon, there might be more HBs, Hg reduction, chance to stop therapy. I think the future of the study, ongoing studies, PEG plus bulevirtide, will bring us more information. And also for patients, with very mild fibrosis, I agree that if the patient is motivated, we go for treatment. But we have also the possibility of clinical trials. So we also discuss clinical trials. But I think that we don't have clear guidelines between combination or monotherapy.
I think it's worth also remembering together that there are data, admittedly based on small studies, suggesting that patients can have long-term clinical benefit after taking a course of PEG interferon, even if they don't have a sustained virologic response. Very famous paper from about 20 years ago from Patricia Farsi, a very well-known Italian investigator who did a lot of important early work in this field, was published in Gastroenterology after a prior paper in the New England Journal on short-term results. And she published long-term outcomes in 2004, showing that patients who took 9 million units of the old-fashioned regular interferon 3 times a week, 10 years later, actually, if they had sustained biochemical responses, not necessarily accompanied by sustained virologic responses, had meaningful improvements in clinical outcomes compared to their counterparts in a placebo group. So that is a point to be made for doubtless be fully informed discussions with patients before we have clear-cut data to guide us if and when bulevirtide comes out. What I mean to say is that we will have to have discussions with patients about the option of adding interferon. So far, it looks like if you add interferon to PEG interferon to bulevirtide at the outset, you do get somewhat higher rates of virologic response while you're on both drugs. But that is not translated into an improvement in what the FDA here in the U.S. now regards as their primary endpoint, which is a combination, a combined response, as they call it, of ALT normalization, plus at least a 2-log reduction in viral load. In fact, with interferon, you get lower rates of ALT normalization. I don't know that that's necessarily a bad thing with regard to disease course, because interferon itself can cause ALT elevations, particularly of a low-grade nature while you're on therapy. So that all needs to be fleshed out. At the moment, I would repeat, I don't see myself, for those willing to tolerate the idea of long-term administration of a daily injectable drug, I'd go with bulevirtide first.
Speaking of long-term benefits of treatment of Hep Delta, we have a question from Abraham, first commenting about the risk of hepatocellular carcinoma is highest among patients with hepatitis delta and that have cirrhosis. But based off of what data are available, does therapy reduce the risk of hepatocellular carcinoma, and by how much? We'll have Dr. Asselah first comment on that, and I'll ask Dr. Jacobson.
Yes, we know that the risk of hepatocellular carcinoma is high among patients with delta cirrhosis. And Ira mentioned the studies from NIH with Patricia Farsi, showing that patients who receive interferon have less cirrhosis, reversal of fibrosis, less cancer, but it's a very small cohort. It's only dozens of patients followed on the long term. So maybe a benefits of interferon on the long term. But this is also debate because it's a very small cohort with very limited number of patients. To bulevirtide, maybe it's too early because it's the studies are having 2 years of follow-up, 3 years, so it's a little bit short to see if this normalization of ALT and delta reduction is associated with reduction of cancer and cirrhosis decompensation. I think there's a rationale, scientific rationale. There's cohorts also from Italy, from Pietro Lampertico, showing in some patients with cirrhosis, portal hypertension on bulevirtide, that there's no clinical complication events when you block viral replication and you have normal ALT. So many believe that if you achieve this normalization of ALT, this HDV RNA reduction to a small level of HDV RNA, it will be translated with a reduction of complication, but it still have to be proven. So I think that it's what is needed in the cohorts, in also the French national INRS cohorts, other cohorts. I think that will be implemented in US, in many countries, to demonstrate that this virological effect is translated into a clinical benefit with reduction of cancer and improving survival. So it's still to be demonstrated.
Thanks, Dr. Asselah. And I know, Dr. Jacobson, you mentioned that long-term study, and I don't know if in that study, they talked about hepatocellular carcinoma in terms of reducing rates or anything. It was a small study, but can you comment on any other data that you're aware of for pegylated?
Yeah, I don't think we're not going to be able to do randomized trials of placebo versus whatever drugs are approved or get approved. I mean, bulevirtide is not going to be approved because it's been shown to reduce the risk of HCC. We know that HDV is associated with a higher risk of cirrhosis by about 2 to 3-fold compared to HBV monoinfection, and a similar increment in the risk of HCC, as Tarik mentioned. I haven't been able to glean from my review of the literature over the years any evidence that non-cirrhotics with Delta have a higher risk of HCC. I think that it seems clearly related to the incremental risk of getting cirrhosis in the first place. So it stands to reason that any therapy that reduces the risk of progression to cirrhosis, as viral control we believe would do. I don't want to say take it on faith. That's not very scientific. But I think we're going to have to be satisfied, at least in the short term, in the absence of a lot of long-term data that will accrue later, that we have, placebo-controlled trials showing you reducing the risk of HCC. We're not going to need that in order to be convinced that we're reducing the risk of HCC by preventing the progression of the disease. Others might disagree and demand a more rigorous evidence basis, but I feel pretty strongly about that. There's no other liver disease where we don't reduce the risk of HCC by controlling the underlying cause. We know that abundantly with hepatitis C, where your risk of getting HCC, if you already have cirrhosis, actually goes down by about 70 or 80% from the time you cure the virus, although to be sure, patients still need to be monitored for that. But I don't need any further evidence that preventing the development of cirrhosis in a non-cirrhotic by eliminating a viral infection or well controlling it is going to reduce the risk of HCC.
I agree that a durable virological response is a surrogate marker of survival. So if we have an HDV RNA undetectable on the long term, I think we have to inform everyone that for Delta, there's always risk of relapse if you don't have HBS loss. So I think that what mistake we've done with Hep C, with Hep C, we know that 24 weeks after the end of the therapy, if you don't have a CV RNA, you are cured if you have RNA undetectable. I think for Delta, we have to be cautious to have long-term follow-up of the patient because we have late relapse. And so what is very important is to achieve this HDV RNA durable virological response. So undetectable on the long term, but so we have to repeat HDV RNA each 6 months during the long-term follow-up and not stop the cohorts, the real life, the data, just 6 months after the end of therapy.
That's such a key takeaway point that Tarik is making. It's one of the most important points that I think we need to remind the audience of, which is that SVR, or sustained virologic response, which is tantamount to virologic cure in Hep C and what we've been used to for many years, has an entirely different definition in HDV. And it goes back to the HIT-1 study and several others showing that the risk of relapse after 24 weeks go by following cessation of treatment, if you're HDV RNA negative, you still relapse. And in HIT-1 with the long-term follow-up, it was about 3.5 years later on average that patients relapse. That raises all kinds of fascinating questions about the biology of the infection and what the virus is doing all that time while it's not relapsing and why it, quote, chooses, teleologically speaking, to relapse eventually. But very, very important point. And it's one of the great conundrums of the field right now and gets to this whole issue of what to do with bulevirtide monotherapy. We know we can't give peg interferon forever. We've yet to learn, we've got a long way to go to learn what happens if you clear HDV RNA and bulevirtide and what the late relapse rates will be. But you never can stop following a patient who's had HDV, no matter how well they've done therapy. And I think it's an important takeaway.
I wanted to shift to some cases that some of our learners are asking about, first starting from a question from college. And first talking about, not having any specific treatment available for active hepatitis delta in patients with decompensated cirrhosis. So first I want to start off with Dr. Asselah and ask his question. How do you manage a patient with HDV with decompensated cirrhosis on a wait list for transplant? Is there any specific management for HDV post-liver transplant other than managing antivirals and Hep B immunoglobulin for, I think, HBIG for hepatitis B?
Exactly. For a patient with HDV with decompensated cirrhosis on the waiting list for transplant, we manage the Hep B, and usually the prognosis is good for Delta. We know this from a long time with the International Registry for Transplantation. So Delta patients are doing well if you manage with antivirals the B. If a patient has a decompensation of cirrhosis but is too old or cannot be transplanted, there's the discussion about bulevirtide. Of course, that interferon is contraindicated in decompensated cirrhosis, in cirrhosis with portal hypertension. But then there's some real-life experience of bulevirtide in patients with cirrhosis decompensation coming from Germany. It was presented at the Global Hepatitis Summit with some interesting results. So if in a country you have availability of these treatments, you have to mention that it's off-label. You know that bulevirtide in Europe is recommended and approved for Delta infection with compensated cirrhosis and HDV replication. But there has been some real life in decompensated cirrhosis showing that safety was okay, and you cannot do anything else than provide these antivirals. So, but just to say that it was off-label, but there was some patients that were reported recently.
There's also, I agree with that completely. And there's recent work from Professor Etzion in Israel and collaborators showing improvements in certain clinical features in patients with advanced cirrhosis and portal hypertension. I think probably we'll learn one day that there's a point of no return where the clinical benefit may be diminutive or non-existent. But yes, I think the horizons have opened up to this idea that even in patients with quite advanced liver disease, including advanced cirrhosis, there may be room for a well-tolerated therapy. I remind everybody what they, I'm sure, already know, which is you can never use PEG interferon in patients with advanced or decompensated cirrhosis.
So this brings me to the next question from Yusuf. And first, I want to take a step back of the question, first ask Dr. Jacobson. So his first part of his question is, do you recommend eltrombopag, which I apologize if I mispronounced that drug name, for the correction of thrombocytopenia in the treatment of hepatitis D when using PEG interferon? And actually, his question is asking for also bulevirtide. But first, I want to ask Dr. Jacobson first, have you used that drug to correct thrombocytopenia to initiate PEG interferon in the past, or even considered or had that discussion with patients?
I personally rarely, if ever, used eltrombopag, even in the Hep C days when it became a kind of hot topic. In hepatitis D, if you're looking at a patient who needs eltrombopag to keep their platelet count up, you're probably giving it to too advanced a patient in the first place to using interferon. Generalizations are always a little hazardous, but I would venture forth with that one for Tarik's consideration, if you'd like to comment too.
I have exactly the same practice than Ira, and I think that I'm not using interferon when the patient has low platelets, and I'm not using eltrombopag. Even in Hep C, in Hep B, in liver disease, I've not used it, only rarely.
Thank you. And so speaking of just completing therapy and thinking of relapse happening afterwards, Dr. Jacobson, can you comment on some of the risk factors that patients might have for relapsing after completing successful therapy with hepatitis delta? And how often, either in the published literature, has that been seen or you've seen in clinical practice?
Maybe one day we'll learn if there were factors that could be identified during therapy, like how long it took for the HDV RNA to become undetectable, or other clinical or laboratory parameters, perhaps demographic features of the patient's degree of liver disease. But right now, I don't think we know.
Just to add, for also relapse after bulevirtide, we know in the phase 2 studies that all patients who stop bulevirtide after a short term of duration of treatment all relapse. Now we don't know if you have 3 years, 4 years of bulevirtide, when can you stop therapy if HBS loss is not achieved. And we know that in the real life, in the French national cohorts, majority of patients who stopped relapsed. Some patients stopped just because of the COVID pandemic, because they were in their countries with no access to treatments, and they stopped and they had this relapse. But we don't know, after a number of years of HDV RNA undetectable, we need surrogate markers or to understand when to stop therapy for long-term bulevirtide therapy.
Speaking of long-term bulevirtide therapy, I think our audience should keep an eye out for what comes out of the upcoming EASL meeting in just a couple of weeks in Vienna. There are a lot of abstracts that look very interesting, some of which bear on much longer, or increasingly long, I should say, follow-up data in patients who take bulevirtide out to 2 or 3 years. There's one abstract title I'm particularly interested in that purports to suggest that if you have a relatively poor response initially, that there's still a chance out to 96 weeks, perhaps in the second year, of good things happening in terms of parameters of response. So very much looking forward to that and other studies. There are a whole bunch of interesting sounding studies on HDV coming out just in a couple of weeks.
You were thinking exactly what I was thinking. My last question was going to be with EASL 2023 coming up. What are some new data that we should be looking out for? So is there anything else to add to that, Dr. Asselah, that you know or have a hunch that will be presented at EASL?
No, I agree with Ira. There will be a more long-term data from the French NRS cohorts, from also Italy and Germany. I think we missed today futility rules. If a patient will be non-responders to bulevirtide, can we stop therapy? Like stopping rules for Hep B with regulated interferon at week 12 or 24. Sometimes we have to go for 1 year, 2 years. So we need futility rules, stopping rules, and also understand which patient who will respond to therapy, so to encourage compliance. So we still to have a better guidance for therapy. We are very happy that we have bulevirtide, we have new therapeutic options, but we have to understand how to treat.
Thank you very much to our faculty, and thank you to our listeners for joining in. Please be sure to check back for more episodes on important hepatitis topics. Thank you and have a great day.